the exact moment a blood clot blocks a major vessel in the brain.
Right, the stakes are instantly astronomical.
Exactly. For years, decades, really, doctors and patients had this very narrow, terrifyingly brief window to go in and pull that clot out.
Yeah, it was a literal race against time. Every passing minute meant, millions of neurons lost forever.
Millions. But what if that window just got blown wide open?
It's a profound shift in how we approach this kind of emergency. We're moving away from this rigid reliance on the clock on the wall.
And instead
we're learning how to look directly at the tissue clock within the brain itself.
I love that phrase, the tissue clock.
Yeah.
So today we're doing a deep dive into the massive new 2026 stroke care guidelines. These were just released by the American Heart Association and the American Stroke Association.
It's a huge document, lots to cover.
It really is. But our specific focus for you today is a revolutionary procedure called endovascular thrombectomy, or EVT, in adults. We've got a giant stack of updated protocols, recent clinical data, expert consensus. We're going through all of it.
And the overarching theme across all these new standards is, it's expansion.
Expansion.
Yeah. The medical community is expanding the time frames, expanding the types of patients who qualify, and essentially rewriting the fundamental rules on how stroke care is delivered when it matters most.
So whether you're a medical professional trying to catch up on the gold standard guidelines, or, you're just a curious learner wanting to understand how modern medicine is literally saving minds, this deep dive is going to arm you with the most cutting-edge facts.
Absolutely.
We're going to unpack exactly who qualifies for EVT, how the treatment windows have expanded from just a few hours to a full day, and crucially, where the physical limits of this technology currently lie.
There definitely are limits, yeah.
Right. So to get our bearings, let's look at the foundational 1-2 punch of modern stroke care.
Well, to understand the intervention, we first have to understand the event itself, right? An acute ischemic stroke happens when a blood clot lodges in a cerebral artery.
It's like a dam.
Exactly like a dam.
Yeah.
It completely cuts off the blood supply to a part of the brain. And the historical first line of defense against this has been intravenous thrombolytics.
Right, IVT.
Yes, IVT. These are clot-busting drugs administered straight into an IV.
And looking at the 2026 updates, there's a very specific note about the medications being used for this first punch, right? Because we've traditionally heard a lot about a drug called Alteplase.
Alteplase has been the standard for a long time, yeah.
But there's a newer option getting a really heavy endorsement now.
Yes, Tenecteplase. The latest consensus gives a strong recommendation for using either Alteplase or Tenecteplase within the first 4.5 hours of symptom onset.
But Tenecteplase has an edge.
It does. It has some distinct practical advantages in a real-world emergency setting.
Like what?
Well, instead of requiring a prolonged infusion that, drips in over an hour, it can usually be given as a single, quick injection.
Oh, wow.
Yeah, and when every second counts, that speed of administration is absolutely vital.
Okay, so IVT, the medication, is our first punch. But today's focus is on the second punch, which is EVT, endovascular thrombectomy.
The physical intervention.
Right. If IVT is the medication floating through the bloodstream, EVT is mechanical. I actually like to visualize it with a plumbing analogy.
I think I know where you're going with this.
Giving the IV medication is like pouring industrial strength chemical drain cleaner down the sink, right? You're hoping it reaches the clog and dissolves the blockage over time.
Exactly.
But EVT, on the other hand, is calling the plumber to physically slide a snake down the pipes, grab the hairball, and pull it completely out of the drain.
That analogy holds up incredibly well, actually. With EVT, neurointerventionalists insert a catheter, usually into a major artery in the groin or the wrist.
And they go all the way up.
All the way up. They navigate that tiny tube through the body, into the neck, and finally into the brain's arterial system to physically extract the clot from those large vessels.
So thinking about the logistics of this in an actual ER setting, if I'm a doctor and a patient arrives early enough for the drain cleaner, but scans show they have a massive clot that probably requires the plumber, I might be tempted to give the IV medication, wait 30 minutes, and just see if it dissolves the clot.
Right, to avoid highly invasive brain surgery if you can.
Exactly. Is there a waiting period to see if the drugs work?
The current guidelines offer a definitive and emphatic no.
No waiting.
All. None. For patients eligible for both treatments, they should receive the IV medication as rapidly as possible, but the medical team should not wait or observe the patient to assess their clinical response. You do not delay the surgery.
So you don't pour the drain cleaner and just stare at the sink?
No, you pour it and immediately call the plumber at the exact same time. You punch with both hands simultaneously as fast as humanly possible. And, the data explaining why we do this is pretty sobering. Researchers looked at multiple major endovascular trials, the Hermes meta-analysis specifically, and they found a really clear correlation.
What did they find?
Among patients who achieved successful reperfusion, meaning the blockage was cleared and blood flow was restored, every single 1 hour delay to starting the surgery was associated with a 5.2% decrease in the probability of achieving functional independence.
5.2%.
Every single hour.
Just to put that into perspective for you listening, functional independence means the difference between walking, talking, and feeding yourself versus potentially needing full-time nursing care for the rest of your life.
It's life-altering.
A 5% drop in those odds every 60 minutes is brutal.
It really highlights why time is brain is the central mantra of stroke care. The analysis showed that at 3 hours from symptom onset, the odds of a better long-term outcome are vastly higher with the surgery than with medication alone. But as the hours tick by, that advantage steadily drops. Any delay, even a 30-minute observation period in the ER, directly translates to worse outcomes for the patient down the line.
Okay, but if every hour costs you a 5% drop in functional independence, what happens to the person who, say, lives alone and isn't found for 12 hours?
The wake-up strokes.
Yeah, the person who goes to sleep feeling fine and wakes up the next morning with a stroke. That leads us directly into what I think is the most massive shift in these new guidelines, which is redefining the treatment window.
Historically, if you had a large vessel occlusion, a major blockage, and you were past the 6-hour mark from when your symptoms started, you were largely considered out of luck for surgery.
Because it was too late.
Right. The risk of the procedure was thought to outweigh any potential benefit. The medical consensus was that the brain tissue downstream of the clot had already died.
But the 2026 guidelines just took an eraser to that strict 6-hour rule.
They absolutely did. Now, for massive blockages in the major highways supplying blood to the front of the brain, like the internal carotid artery EVT, is highly recommended between 6 and 24 hours from symptom onset.
A full 24 hours.
It's a game changer.
That is a quadrupling of the treatment window. But physiologically, how is that even possible? I mean, if a section of the brain is starved of oxygen because the main highway is blocked, how is it surviving for an entire day?
The answer lies in collateral blood flow, and crucially, our ability to see it with advanced imaging.
Okay, break that down for us.
We aren't just blindly hoping the brain is alive after 24 hours. We are proving it before we ever operate. Doctors now use automated perfusion imaging, usually an advanced CT or MRI scan, to look for what we call a mismatch.
Let's talk about this mismatch. What exactly are the two things we're comparing on these scans?
We're comparing the core to the penumbra. The ischemic core is the area of brain tissue that has already suffered irreversible cell death. It's gone.
Okay, that's the core.
Right? The penumbra, however, is the surrounding area of brain tissue. It's starved of blood and oxygen, and it's electrically silent, which is why the patient is experiencing severe stroke symptoms, but the tissue is not dead yet.
So it's essentially stunned.
Yes, it's in a state of suspended animation.
Yeah.
And it survives because of those collateral vessels. If the main highway is blocked, the brain has a network of tiny back roads.
Oh, I see.
Yeah, these back roads can't deliver enough blood for normal function, but they provide just enough of a trickle to keep the cells on life support.
Wow. So the imaging software calculates the volume of dead tissue in the core and then calculates the volume of stunned tissue in the penumbra.
Exactly.
And if there is a big enough mismatch, meaning a small core but a massive penumbra, the doctors know there is still a large amount of brain tissue left to save, even if it's been 20 hours.
And that changes everything. It completely rewrites the rules. And by the way, the guidelines also specify that this 24-hour window isn't just for the front of the brain anymore. Yeah, they now provide a strong recommendation for treating blockages in the basilar artery, which supplies the posterior circulation, the back of the brain, within 24 hours, provided the patient has a high stroke severity.
Like an NIHSS score of 10 or more.
Exactly. And the posterior circulation controls fundamental life functions like breathing and swallowing, so expanding this window is a monumental step.
The imaging really is the key that unlocks the door to surgery. But if imaging tells us what's savable, what happens when the scan comes back and says the damage is already massive?
Right.
Because we just established that the core is irreversibly damaged tissue. What if the imaging shows that the core is huge?
This brings us to the large core paradigm shift. It is arguably one of the most highly anticipated sections of the 2026 updates.
Let's get into it.
To understand it, we need to quickly look at how doctors measure that damage using the aspect score.
Right, the Alberta Stroke Program Early CT Score. How does that scoring system actually work in practice?
It's a 10-point scoring system used on CT scans to quantify the extent of early stroke damage. A score of 10 is a perfectly normal brain.
Okay.
For every distinct area of the brain that shows signs of lack of blood flow, you subtract a point. So a lower number means a larger core of damaged tissue.
Makes sense.
Historically, if a patient came in with a large core scoring a 3, 4, or 5 out of 10, they were entirely excluded from EVT. The plumber would pack up and go home because the assumption was the brain was too far gone.
I have to admit, logically, that historical approach makes total sense to me.
It did to most people.
Right. I mean, if the core is explicitly defined as irreversibly damaged, infarcted tissue, why would we ever risk invasive brain surgery to restore blood flow to an area that is already a graveyard?
Exactly.
I would imagine there's a massive risk of causing severe bleeding if you suddenly pump high-pressure blood back into dead vessels.
That is the exact concern the medical community has wrestled with for years. But the recent data from trials like SELECT-2, Angel Aspects, and Tesla completely challenges that assumption.
What did the trials show?
They looked specifically at these large core patients, the ones with scores of 3 to 5. And the findings were astonishing. EVT actually provides significant functional clinical outcomes and reduced mortality even for these patients with large predicted cores.
Wait, so the guidelines are now strongly recommending surgery for these patients?
Yes, giving it a strong recommendation for patients under 80 years old presenting between 6 and 24 hours, provided the brain isn't swelling dangerously with, a mass effect.
But the mechanics of that are tripping me up. How do you improve a patient's function by restoring blood to dead tissue?
It comes down to a really fascinating nuance in how we interpret diagnostic imaging. Decreased density on a CT scan, those dark spots we see, they're very good predictors of cell death. But researchers have discovered they are not 100% synonymous with entirely irreversible tissue loss.
Wait, so the dark spots on the scan? Some of those cells are just playing dead.
In a sense, yeah, the imaging suggests it's a dead core, but metabolically, some of those cells have just shut down completely to conserve energy.
Oh, well.
When you actually restore the blood flow and deliver oxygen, some of that tissue in some patients recovers. The strict definition of what is truly irreversible is getting really blurry.
That challenges our whole understanding of the scan. The machines are telling us it's too late, but the clinical trials are saying go in anyway, the patient actually does better.
It's a realization that is saving lives, and it pushes the boundaries even further. The guidelines actually give a moderate recommendation for EVT in select patients with an aspect score of 0 to 2 within the first 6 hours.
A score of 0 to 2. That means almost the entire territory of the artery looks damaged on the scan. It's a massive stroke.
Yes, it is. A recent trial looked at these massive strokes, and while the overall outcomes are predictably severe given the sheer size of the stroke, 13.3% of the patients who received the surgery achieved functional independence at 90 days.
Versus what for the medication alone?
Compared to only 7.5% in the medical treatment group. The guidelines do stress that deep discussions with the patient's family are absolutely essential here to balance the benefits with their values and expectations because, the underlying condition is so severe.
Of course.
But the medical option is now officially on the table.
So the rules of when we operate and who we operate on have completely changed. We can go in up to 24 hours late and we can tackle blockages even when the brain looks like it has sustained massive damage.
Exactly.
But I want to look at the how. We've talked about the plumber snake, but what exactly is going up into these blood vessels to pull these clots out? And more importantly, where does this technology fail?
Well, the primary tools recommended are stent retrievers and contact aspiration.
What are those?
A stent retriever is a self-expanding wire mesh tube. It's deployed inside the clot. The mesh expands and integrates into the clot material, and the whole thing is pulled out.
And the aspiration.
Contact aspiration is essentially using a catheter, like a miniature vacuum cleaner, to suck the clot out.
Or they use a combination of both to make sure they get it all.
Exactly. The stated goal is to achieve an extended T-psi grade of 2B, 2C, or 3, which is basically perfectly normal or near normal blood flow restoration.
Right.
As for the procedure itself, the data shows that the patient can be under either general anesthesia or procedural sedation. Both work equally well to facilitate the surgery safely.
Okay, I'm picturing the actual surgery here. If we are physically scraping a clot out of an artery, dragging a metal mesh through a vessel, I'd assume the standard practice is to give the patient some heavy blood thinners right beforehand.
Do you think so, right?
Yeah, just to make sure a new clot doesn't immediately form around the tools or the irritated vessel wall. Is that part of the protocol?
It sounds totally logical, but the guidelines are actually definitive on this.
Okay.
Preoperative administration of a specific anti-clotting drug called tyrofeban before EVT is explicitly not recommended
Really? Why not?
because it provides no functional benefit to the patient and it actually results in a higher incidence of symptomatic hemorrhage.
Oh, that makes sense.
Yet you're already dealing with fragile brain tissue. Adding an aggressive blood thinner right before you mechanically intervene significantly increases the risk of causing a catastrophic bleed in the brain.
Okay, so we know what to avoid during preparation, but what about the physical location of the clot? Are there places in the brain where the tools just cannot go?
Yes, and this is a crucial boundary established by recent trials, like Escape Mevo and Distal. Up until now, we've been talking about large vessel occlusions.
The major wide highways of the brain.
Exactly. But researchers also looked at medium and distal vessel occlusions.
So the smaller branches, much deeper inside the brain, the side streets and alleys.
Precisely. And what the data revealed was that for these medium and distal vessels, the surgery provides no benefit over standard medical management.
Not at all.
None. In fact, using stent retrievers for these smaller vessels actually increased the risk of death and caused greater rates of hemorrhage.
Wait, doing the surgery made the stroke worse. How?
It comes down to the physics of the tools versus the anatomy of the brain. Stent retrievers are designed to expand outward to grip the clot.
Right, the mesh expands.
But these distal vessels are tiny and incredibly delicate. The outward radial force of a metal mesh stent is simply too aggressive for those fragile pipes. You run a very high risk of puncturing or tearing the vessel wall entirely when you try to deploy the tool or drag it out.
So EVT is strictly a large vessel tool right now. The stent retriever is just too big and too stiff to be navigating those tiny branches safely.
That is the limiting factor, yeah. The guidelines state clearly that we need the development of new, specifically designed techniques and tools for these medium and distal vessels before we can safely intervene there. We have to respect the limits of our current engineering.
So bringing this all back home to you, the listener, what does this deep dive mean for your life or, the life of someone you love? If someone shows signs of a stroke face drooping, arm weakness, speech difficulty, the landscape of what happens next at the hospital has fundamentally shifted.
Completely.
Yeah.
The biggest takeaway is the medical community's shift away from a mindset of inevitability.
Right.
For decades, a large stroke presenting at 8 hours or a scan showing massive damage meant transitioning to palliative care. Now it triggers immediate advanced imaging and a rush to the operating room.
Too late or too severe are simply no longer automatic death sentences for brain function. We are punching the clot simultaneously with IV medication and mechanical surgery without waiting to see what happens.
Exactly.
We have expanded the treatment window to a full 24 hours. We're successfully treating large core strokes that were previously thought to be completely lost causes, all while respecting the physical limits of our tools in the smaller vessels.
The integration of advanced imaging has truly turned the stroke protocol into a highly personalized rescue mission. Medical teams are treating the individual patient's unique physiology, not just blindly following a clock on the wall.
Which leaves us with one final lingering thought. In the knowledge gaps and future research section of this 2026 document, the authors explicitly state that we urgently need research into a thrombectomy window for patients who are more than 24 hours from symptom onset.
The implication of that research direction is massive.
It really is. Think about what that implies for the future of medicine. We've pushed the boundary from 6 hours to 24 hours by finding that stunned, silent penumbra.
Right.
But if brain tissue can sometimes survive a blockage for a full day, relying on just a tiny trickle of collateral blood and still be rescued, what is the true absolute limit of human brain preservation?
It's a profound question.
Could there be a future where a stroke remains reversible 2 days or even 3 days after it happens? That clock starts ticking the moment a vessel blocks, but perhaps the countdown is much, much longer than we ever dared to hope. That is something for you to ponder.